Hello everyone, I'm Dr. Jack West, medical oncologist and founder and CEO of the Global Resource for Advancing Cancer Education, or GRACE. We're going to continue with the next part of our program on molecular markers in lung cancer, who to test and what to test for. I was joined in this program by Dr. Charlie Rudin at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins University in Baltimore, Maryland. Also Dr. Alice Shaw, assistant professor and thoracic oncologist at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts. Also Dr. David Spiegel, thoracic oncologist and director of clinical research and the lung cancer program at the Sarah Cannon Cancer Center in Nashville, Tennessee. And finally, Dr. Glenwood, or Glenn Goss, the chair of the Lung Cancer Committee of the National Cancer Institute in Canada and professor at the University of Ottawa in Ontario, Canada. We talked obliquely about this already, that we may be moving from the time of selection based on smoking status and even histology to a broader platform for other people. So I guess the question of, does smoking status matter to you to the extent of having someone with a minimal or no prior smoking history? If they have a squamous carcinoma, would that vault your level of suspicion and interest in testing? Or does histology trump that?
I always laugh when I'm at meetings with my colleagues from Boston, just because where I am in the Southeast, smoking is everywhere. And so most patients I see with lung cancer have a strong history of smoking. But I can tell you, and Alice showed the data, it's not like you can't find driving mutations in those patients. Now, for squamous patients, personally, that's the way I approach them, is if they haven't smoked in a long time or they've been light smokers, because you do find some patients with squamous cancers like that. I do test them, although it's anecdotal. I have not yet found any of these driving mutations in those patients. Is that the way you test everybody?
So we test everyone, but for squamous patients, for me, it's a timing thing. So if it's a patient with squamous cell and they have a heavy smoking history, we do have a squamous sort of panel, which is a snapshot panel, which includes pretty much what you showed for the LCMC and some of the amplifications I showed on the pie chart, so FGFR, PDGFR. If it's a squamous who also has a light or never smoking history, then I will also at the same time add an ALK, for example. So I just move things up in timing depending on their smoking history. But at some point, if a patient with squamous cell smoker is negative for everything, they will, or at least they have the option of getting the complete panel.
And for our listeners, a snapshot panel is
So it's pretty much what Dr. Rudin showed, which includes EGFR, KRAS, BRAF, PIK3CA, kind of the most common oncogenic mutations that we know about in lung cancer.
Could I ask Alice to comment on another issue, and that is, for the mutations that have a low frequency in the squamous group, there has been at international meetings discussion about contamination in those tumors. In other words, what I mean by contamination, I mean that even though you can't see a large adeno population in the tumor, there have to be some adenocarcinoma cells, and that's why you're seeing the mutation. That in really pure squamous cells, you never see EGFR or ALK. Would you like to just comment on that?
It's going to be somewhat anecdotal because in our experience, we definitely have pure squamous carcinomas that are ALK positive and EGFR mutation positive. I would say in our experience, what I have seen is that pathologists can read the samples differently. And so we have had a number of cases that were sent to us as squamous cell and a never smoker. Do you want to do testing or not? And when we've looked at it with our pathologists, they thought it was really poorly differentiated adenocarcinoma. That's something that I see more commonly.
I think this issue of who to test is still something that's up for debate. And clearly, I think all five of us have slightly different approaches to how we do that. At Hopkins, our approach is reflex testing of anyone with adenocarcinoma. Squamous is really up to the doctor seeing the patient, whether they send and what they send.
Are we at a point where lung cancer should be like breast cancer, where when you're diagnosed with breast cancer, it is routine to test for estrogen and progesterone receptors and for HER2/neu status? Are we at a point, are you all working at institutions where reflex testing that is immediate from the beginning, don't ask whether you should do it or not, it is done routinely, should be done? And then as a second point of that, is there any concern that there could be a downside to that by exhausting the tissue that's available when there could be something more timely for a clinical trial down the line that no longer has tissue available? Maybe someone who can speak to that.
Yeah, it's a pretty interesting topic. It's something we've been working on a lot at our center. The term reflex testing, as you imply, is you don't have to ask for it. It's done automatically by the pathologist. So I do firmly believe that reflex testing should be in place, at least at community centers, for a couple of reasons. And we've moved our center to entirely reflex testing, just like Dr. Rudin at Hopkins, in the sense that all non-squamous tumors reflexively are tested for EML4 ALK and EGFR. The reason I think it's important is you get your answers a little bit quicker. You're not taking that extra step to meet the patient in your clinic and then ask your clerk to go make a phone call or send a request to get that tissue sent. It's already been done, just like it's done in RAS testing is done in colorectal cancer. Now, RAF testing is common for anyone with melanoma, and as you mentioned, ER, PR, HER2 testing in breast cancer is standard. There's a lot of pitfalls, right? The two that I've encountered right now that I think are hard, and we have some guidelines coming out from CAP, a National Pathology Association. Number one is the doctor who may not know what all that means. So he's getting a report, and he doesn't really know what EML4 ALK is and what to do with those results, or what is a positive result. I have a deletion or an extra copy. Is that positive? So I think there's an education issue, at least in the community I've been seeing. And then I worry a little bit for our early stage patients. So patients with stage 1 or 2 disease who are coming back with reports that say they have an EGFR mutation. What do we do? And our insurers covering that kind of testing. So there's a lot of sides to this coin, I guess.
To address the second part of your question, and that is running out of tissues. Lillian Su actually has published this beautiful paper, I think she published in JCO a few years ago, where they surveyed patients and physicians about repeat biopsying. And clearly, the physicians are much more conservative than the patients are in terms of having a repeat biopsy. In general, the majority of patients, and these are generalizations because I'm not quoting directly from the paper, but the majority of patients, if they feel that is going to benefit them, will undergo a second or subsequent biopsy. Whereas doctors are reluctant to put their patients through additional biopsies. It's a cultural thing that we have to move away from as physicians. Mm-hmm. We have to be more inclined to ask our patients whether they're prepared to undergo further biopsying. So I don't think tissue is actually the major issue.
Thanks. And I do think that the point about not having dead time between the time that the biopsy is done and when you see the patient is an important one, because it's often a week, 10 days, 2 weeks even, and that time could be spent having the lab test done, or you start the clock at that point. And that's a big difference for the patients who are often saying, well, my first chest x-ray or CAT scan was done 4, 5, 6 weeks ago. I feel it beating down on me. Another question came in. If somebody comes to you and they haven't had testing done and you're chasing down tissue, how do you feel about starting chemotherapy in the meantime? Is there a real downside to doing that?
Well, as Glenn pointed out, I think there are practical reasons that sometimes that's a necessity and, in fact, a good thing to do. Sometimes people get diagnosed with a very small needle biopsy where there really isn't sufficient material other than to just make the diagnosis. And the question does come up, do you delay their therapy? Do you put them through repeat biopsy? Is there risk associated with that? Or do you just proceed? You sort of have to approach it on a case-by-case basis. For many patients, a couple-week delay is not going to alter their clinical course significantly. But it's very psychologically difficult for patients to sit and not get treatment for a long period of time. And a couple of weeks is a long period of time. And there are patients who need to be treated.
It's surprisingly common. People come, they've only had a bronchoscopic biopsy and they have an FNA, just a smear even. And so even though they've already been diagnosed, when we're meeting them, maybe as a second opinion, we have to go through another whole biopsy that will maybe take a week to set up, and then another week to wait for pathology, and then potentially 3 weeks for genetic testing. So it means 5 weeks from when you met them, which might be, like you said, maybe 8 weeks even from when they were diagnosed.
And don't forget the added hurdle. You get the result, you want to write the prescription, and then you have to deal with copay issues and things like that. They could add another week or two.
When I hand someone a prescription, I pretty much presume that it's going to be a week or 10 days, even 2 weeks before they actually can start the drug after all the negotiations begin. So that's a point well taken. And it brings up an issue that we're right in the middle of, and that is getting enough tissue. And that's something that I think it's worth having the general patient audience know and tell everyone they know about is however much tissue you think you need, get twice as much as that. And I have been advocating for a unit of measurement called a boatload of, I mean, there's never enough tissue. At our institutions, I think many of the pulmonologists know to get core biopsies as opposed opposed to an FNA or a fine needle aspirate, which is just a very limited amount of tissue. Now, 10 years ago, when it didn't matter what subtype of cancer you had and when all you needed was enough tissue to diagnose it, the least invasive procedure was great. But now, that is just a starting point, and it doesn't save anybody anything when you have to go back and redo the procedure 2 times, 3 times to get what you really need to give the best therapy.
As far as EGFR is concerned, which other than RAS is the most common mutation, it would appear that if you have the mutation, it doesn't matter when you get the drug in your history. So that deals with this waiting. Alice could probably comment on ALK as well, because there's data in ALK as well. So if you have an EGFR mutation, I'm talking about a sensitizing mutation. If you have an EGFR sensitizing mutation and you have chemotherapy first, it doesn't mean that the EGFR inhibitor is going to work less well in the second, third, or subsequent lines of treatment. The data suggests that they work equally as well, regardless of what line of therapy it is. What the data does show, though, is that as the patient's performance status deteriorates, that they respond less well to EGFR inhibitors.
And then what we all know is true is the course doesn't always go perfectly. So you think, oh, we'll just do that in 8 weeks or in 12 weeks, but then a complication develops, they never get access to the pill. That's the concern for me, is not giving somebody a chance to get a therapy that may be their best therapy.
Yeah, that's fair. I mean, you know that you have something that is overwhelmingly likely to be the best treatment for them. You don't want to wait too long. I think that's different from starting a therapy and then while you're pursuing all the molecular testing, going through the initial 6 weeks of therapy. The dilemma comes maybe when you find out someone has a mutation and they are responding to chemo, but it's not the worst dilemma to have. How much does the need for a new biopsy affect your enthusiasm for pursuing molecular testing, particularly if somebody has a pretty low pretest probability? I understand the general idea that, yes, it's really great to have tissue and do molecular testing on as broad a population as you can, but if someone comes to you, it's been 4 weeks, they have a fine needle aspirate, and they have a smoker with a squamous cancer and a very low probability, are the people who are doing testing of as broad a population as possible less enthusiastic about it in those settings?
I think it's patient-driven. I think the answer to that question is patient-driven. There are individuals who don't want their tumors tested at all and not prepared to go through any other biopsies other than their diagnostic biopsy. So your inclination to test and to pursue that is low. There are other patients that want everything done and they're prepared to go through many discomforts in order to get the absolute optimal treatment. And I think that patient you'd be inclined to put through a biopsy. So I think to a large extent it requires a discussion with the patient.
I would agree with that completely. The patient drives a lot of it. We, of course, strongly usually recommend biopsies. And part of it is because we have more and more knowledge about squamous cell carcinomas and how they do have the potential to have some of these oncogenic drivers. I mean, FGFR amplification was reported in about 20% of patients in a paper from last year, and there are FGFR inhibitors. So 20% PIK3CA mutations, which involve a gene called PI3 kinase, and there are PI3 kinase inhibitors, many of them in clinical trials. Those mutations are in about 10% of our squamous patients. So now we're adding up to 30% or 40% even, where you could have potentially a targeted therapy. So I think if a patient is interested and willing and there is a biopsy that can be done safely, then we usually do encourage it.
The only thing I want to add, I entirely agree that patient drives it if they know about this. A lot of patients obviously come into the clinic knowing what they want, have heard about this, but I think there's a lot more patients that don't know anything about what Tarceva or EGFR means. And I worry that unless the doctor or some healthcare professional is having that conversation with the patient, they're not going to have a chance to drive the decision-making about whether they get a biopsy or not.
Yeah. They have to be properly informed.
KRAS mutations are the most common one in the lung cancer mutation consortium, and that really corroborates what's been seen elsewhere. What do we have to recommend for those people in terms of how do you use that information, and are there agents or molecular classes that are looking most encouraging for someone who you test in or outside of the lung cancer mutation consortium with a KRAS mutation?
You know, KRAS has really been one of our most frustrating areas. We don't have a good answer for KRAS. We have things that are being actively tested, and there are multiple clinical trials now in that subset of patients that I think may show a way forward, but it's been a very tough one. KRAS was one of the first oncogenes to be described, and there have been many attempts over decades to try to develop specific inhibitors for KRAS mutant tumors, largely unsuccessful, which isn't to say that we don't have good ideas now, but it is a tough area. I'd point out pancreatic cancer, which is one of our toughest cancers in terms of outcome. About 90% of those are KRAS mutant. We really don't have good therapies for that.
We'll continue in the next podcast with a presentation by Dr. Spiegel on the appeal and challenges of incorporating molecular marker studies into a new era of clinical trials divided by subsets. Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.